agent for irritability. What about obtaining a sleep study? Fair enough. And what about obtaining an EEG? Okay. So here, the first sort of route was obtaining an EEG. I understand why those who raise your hand with a sleep study, and Dr. McCracken will be talking about that a little bit as well. But really why I want to present this is we're going to highlight some of these associations or risk factors that particularly predispose these individuals with autism to epilepsy, but also noting that in your practice, you may often see a change in just behavior that could be secondary to new onset seizures in an adult, right? Not a child, but an adult with autism and intellectual disability. So let's talk about that a little bit more. So what do we know? We know that epilepsy rates are higher in autism. Seizures have been described since the very first cases of autism, since Lee O'Connor's work in this. And those rates that have been described are very variable, higher rates from anywhere from 5 to 45%. And really, this is due to variance in how these data have been ascertained across studies. So for example, data from tertiary medical centers or data on adults with intellectual disabilities, which we'll talk about, are going to have much higher rates compared to maybe community-based data or those without intellectual disability. But with that range, that prevalence range, we have sort of a agreed upon among the neurology community that it's about 15 to 30% higher rate in autistic individuals compared to the general population. We also know now, for a while, but maybe not previously when we first were studying this, that this prevalence increases with age. So about starting at 12% in childhood and reaching all the way to 26% in adolescence. And again, honing in on the fact that it can also occur in adulthood. And I note this because I have many adult colleagues who sort of come and say, I'm surprised, first-time seizure at 30 years of age. Or I have families who come to see me for the first time. As a child neurologist, I also see many adults that say, I thought this was only going to happen in childhood. We didn't expect this. And so it's thinking about how you're counseling your patients when you're seeing them in the clinic as well. And so this sort of meta-analysis kind of hones in on some of these prevalence rates. So this was a 2019 systematic review where they took about 74 studies reporting on over 200,000 patients, and they looked at the prevalence of epilepsy and autism in epilepsy. And what they found were sort of within that range that we talked about. Epilepsy and autism being about 12%, with a range all the way up to 60%, particularly in a study of adults with intellectual disability, and autism and epilepsy being about 9%. So a link there that we'll talk about briefly as well. Even when excluding for genetic conditions or developmental encephalopathies, those rates still stayed pretty similar, clearly indicating that there is a connection between the neurobiology of both of these conditions. Also finding that epilepsy in females with autism is much higher than those in males, and again, we'll talk about that as well because that's been consistent across many studies too. And so why is there a higher risk in autism? I'm actually going to really just briefly touch on this, but have for you guys the information here and studies that you can look at. But it's thought to be a lot of different converging mechanisms, particularly in genes, and this idea around imbalance of excitatory and inhibitory function. So mainly this sort of dysregulation of either GABAergic fibers or GABA receptor function. And there are several genetic neurodevelopmental conditions that we have studied that are highly predisposed to both epilepsy and autism that have given us a lot of this information in understanding the neurobiology. There's also been long-standing discussion of whether primary epilepsy may impact synaptic plasticity and cortical connectivity, which in turn predisposes this developing brain to cognitive delays and behavioral impairments. For example, cases when we think about infantile spasms or Dravet syndrome, very early onset epilepsies that have high rates of autism as well. So what are some of the other associated factors that you're going to want to think about in your clinical practice when an autistic individual comes in and you're counseling or thinking about epilepsy? Well, intellectual disability being one of the number one factors that has been shown across many studies, and even in studies looking at large cohorts of data or databases when controlling for many other factors, it's really intellectual disability that stands out that increases these epilepsy rates. I note one meta-analysis here that many people go to all the way back from 2008 that really indicated those with epilepsy and autism and intellectual disability having a 20% higher risk of epilepsy compared to those without. Genetic conditions, as I mentioned before, can yield up to a 2 to 5-fold higher risk of epilepsy. So these are genetic conditions like tuberous sclerosis complex, duplications in 15q, Fragile X, Angelman, Rett syndrome, in which there's high rates of autism as well as epilepsy. And in some cases where it might even be indicative to get a screening EEG prior to the onset of epilepsy, as we know in studies of TSC, for example. Female gender has been one that's had some mixed results. Most studies show, but not all, that there's higher rates of epilepsy in females with autism. One of the sort of thoughts behind this, or these studies behind this, is that many females with autism may tend to have a more severe intellectual disability compared to autistic males, hence leading to this sort of higher risk of epilepsy or genetic burden leading to higher risk of epilepsy. Developmental regression is another, and we're not going to spend a lot of time talking about that today, but I'm happy to answer questions during the Q&A about this because it comes up clinically. But very briefly, there are developmental regressions that we think about in autism that often happen around that 18 to 24-month period where you think about typical autistic symptoms presenting, increase in rigidity, reduction in eye contact. So we're talking about a primary sort of behavioral, subtle regression looking more like autism symptoms versus a very global language regression or developmental regression that might be associated with an epileptic encephalopathy. So when you just take this more autistic regression type symptoms and look at whether or not those individuals have higher rates of epilepsy, essentially there's sort of mixed data, but overall showing that there is not a connection. Those individuals are not necessarily presenting with higher rates of seizures or epilepsy, leading to these more subtle behavioral regressions. Pre- and perinatal factors have also very much been shown. So in the finished birth cohort, showing that prematurity, low birth weight, and low APGAR is being associated with higher rates of both autism and epilepsy. So now looking back to that first case, we think about an autistic male, so autism, intellectual disability, history of prematurity, much higher associated factors for having epilepsy, right? So let's think a little bit about differentiating seizures between behaviors, autistic behaviors. And this is many questions oftentimes my child neurology colleagues who may not be in neurodevelopmental disabilities or my colleagues in developmental behavioral pediatrics or child psychiatry are asking. And sometimes, frankly, it can be hard to distinguish. Even if we think as neurologists, it's very easy maybe to distinguish some of these things. In seizures, you might think of a change in mental status or an unresponsiveness or abrupt change in these things, versus in maybe some of these more well-described autistic behaviors, we think about not responding to one's name or in their own world for long periods of time, particularly maybe when pushed to do activities that they may not want to do. In seizures, we think of brief, stereotyped, rhythmic, and synchronous movements. In autism, we might think more about body tensing, atypical motor stereotypies that are less, although maybe synchronous or stereotyped to a nature, not synchronous, are asynchronous or not happening in these brief sort of abrupt periods of time. We might think of automatism in seizures, as we know, right? Facial automatisms, twitching of the mouth, of the hand, versus these more motor stereotypies in autism of the hand kind of coming around and around like this or up in the air. And again, a sort of synchronous, happening more when excited, happening more in periods of time to calm themselves. In seizures, we think about a frank eye deviation versus in autism, and interestingly enough, even my own colleagues in our autism clinic, until they see it, we don't recognize that actually a behavior that we might be looking for is atypical peering at objects, right? So I've had autistic patients I take care of who aren't just pulling up an object and peering at it like this, but really deviating their entire eye during this period of time with no other symptoms that are present at the same, right? But I can't emphasize how much collateral information is important. Going back to our case in terms of what the caregiver was noticing as well. There are plenty of times where parents have said something is off, but now the therapists are saying, this is different than the other kids or adult that I take care of. They are losing periods of time. They're regressing. They're not remembering things they should be remembering. And that, I think, should really clue you into thinking about whether or not you want to get an EEG and screen for seizures. So what are we kind of still learning? Well, we're still learning more about what these EEG abnormalities are that we can find in autistic individuals. So spikes and other nonspecific abnormalities occur on EEG in about 5% of the general population. And in autistic individuals, this can raise up to 60%, showing these nonspecific findings on an EEG, like slowing, temporal spikes, that really are not seizures or indicative of treatment. And I'll kind of say that again. Spikes are not indicative of treatment, right? There's been a lot of discussion. There have even been studies looking at this. But we are still learning how these EEG abnormalities might impact development. And there aren't very good prospective studies of large cohorts of individuals to understand this. But there have been papers showing that they might be doing something. So this paper from 2019, led by Dr. Jamie Kapal, a pediatric neurologist, was a retrospective study about 500 autistic individuals from their from their database. 5% had epilepsy at the time of autism diagnosis, and 25% had autism but no epilepsy, but an abnormal EEG result. And essentially what they found were that the group with an abnormal EEG on measures of adaptive function and developing showed lower scores compared to the normal EEG, the one with normal EEG, and then not surprisingly, the group with epilepsy showed lower scores compared to both groups. So, retrospective study, maybe lots of factors, but again indicating that perhaps there is something with these spikes that could be impacting cognition or development in some way. And many people looking at this. But again, as of now, for the practice parameter, we do not recommend the treatment of these spikes because the benefits don't outweigh the side effects and the risks. So what is the recommended workup? The American Academy of Neurology and American Academy of Pediatrics do not recommend a routine EEG for children with autism. So despite these higher rates, it is not indicated that every autistic individual obtain and get an EEG. And I'll be honest, I see this very commonly happen, and parents then coming and saying there were abnormalities, what does this mean? Or coming to me and saying my child's having seizures, my adult child is having seizures, what should we do about this? And so even if you are going to get an EEG when it is indicated, or you're not sure, which makes sense to get, what I find is very helpful is counseling these families before the EEG about what we could potentially find. And then, of course, re-counseling again after the EEG. I think that really helps going in to understand, but also alleviate or attenuate a lot of concerns that come up when they get that report now, before we've called them or before they're looking at it and they're wondering what these spikes mean. It's indicated to obtain a prolonged sleep EEG if there's an evidence of clinical seizures, a history of developmental regression in toddlers and preschoolers, older age, particularly a significant language regression, situations with a high index of suspicion that epilepsy could be present. So examples are these known genetic syndromes that confer a high risk of epilepsy. So for treatment, it's because essentially of the tremendous heterogeneity in seizure type, there's not one gold standard treatment of epilepsy and autism. The decision is very multifactorial: seizure type, side effect profile, other co-occurring conditions, which Dr. McCracken will touch upon today, where we might think about AEDs that could be targeting both of these things, other co-occurring neurologic conditions like migraines or headaches. A dosing schedule could be very important, as well as dosing type, right? Whether or not a child can take, or even adult, a tablet, right? So we have to think about chewables or sprinkles or liquid formulations. And we do want to be mindful that certain side effects can be amplified in individuals with autism, particularly behavioral. But again, I also want to emphasize this does not preclude us from using specific medications. So I do use levetiracetam to treat seizures in many of my autistic patients and patients with intellectual disability, even those who have lots of behavioral challenges or irritability, because it is still a good medication to treat these things. I have no stock in Keppra, as you saw my disclosures, but it doesn't require blood work. And so I, again, want to emphasize the fact that sometimes I see providers stay away from things like clobazam or levetiracetam, but they can be considered. You just want to be more mindful about monitoring for these side effects and counseling the families. Okay, we're going to move from that domain, seizures and epilepsy, and move on to the next thing, which is motor impairments in autism and neurodevelopmental disorders. So what do we know? We know that motor impairments or dysfunction or challenges or delays are highly prevalent in autism and a broad range of neurodevelopmental disorders, and namely neurogenetic conditions, which we're not going to talk about today, where motor impairment may really be one of the first features of atypical development in these individuals. So this language is taken directly from the DSM-5. In autism, motor impairments are an associated deficit, such as odd gait, clumsiness, other abnormal motor signs. In ADHD, it's noted that delays in motor often occur, and it is not unusual for us to see fine motor delays, gross motor delays, difficulty in handwriting for those with ADHD. And in intellectual disability, not surprisingly, delayed motor, language, and social milestones may be identifiable in the first 2 years of life. So what do we not know? Or in other words, I guess, what are some of the gaps still around motor impairments, even surprisingly within the field of neurology? Well, they are still quite often under-recognized and under-screened for by clinicians. There are really no standardized guidelines on how to evaluate or categorize these impairments. And you go back to the language, and it's not surprising, right? When you think about other abnormal motor signs, maybe that means a little bit more to us as neurologists, but it's really hard to still understand in our own right, how do you categorize that? So far, most of the tools that we've used to sort of assess these motor impairments, or even in general screening in the pediatric clinic, is focused on motor milestones, right? Do they or do they not achieve a specific milestone? It's not really capturing in an objective way more qualitative aspects of these movement differences that we often see and tremendously impact overall development. So still a lot of work to be done in that area and some work that we're doing at UCLA. So I choose this study because it highlights a couple of things. This was a population-based cohort study in Australia of 2,000 individuals with autism. They found that about 35% of them met criteria for motor difficulties, about the same rate as intellectual disability. That prevalence of motor difficulties increased with age. So again, this is not a childhood problem. This occurs all the way through adulthood. But diagnosing clinicians only reported motor difficulties in 1.3% of cases. So again, highly prevalent, but under-recognized and underdiagnosed. And we'll talk more about why that's important. And I should note that more recent studies have even shown rates up to 50 to 80% of individuals with autism having motor impairments or motor challenges. So we also know that these motor impairments have a cascading negative impact on many other developmental domains, right? So motor dysfunction is not isolated to motor. There have been a lot of studies and a lot of literature showing how different motor domains, when impacted, fine motor, gross motor, quality of walking, can impact expressive language, development of language and communication in autistic individuals, and things like adaptive function and higher level motor skills, which are important. So domains that are very, very important for any developing child and particularly impacted in autistic individuals. And I'll highlight in this last sort of paper that we recently published, again, going back to how data is generally ascertained, we actually found in this cohort that all of these autistic toddlers met an on-time walking onset, so in a typical range of walking. Yet even when they started to walk, they showed a lot of atypicalities in the way that they walked, namely slower measures of pace, quantitative measures of pace, and that was related to lower communication scores and adaptive functioning scores. So I'll highlight again a little bit later on clinical considerations and tips, but thinking about in your clinic, even when milestones are achieved, thinking about other motor difficulties that could be present. We also know that these motor challenges have profound impacts on physical health and well-being for these individuals. These delayed motor milestones often lead to more sedentary behaviors, reduced peer interactions, more screen time, reduced physical activity, only further compounding often medical conditions we see in these populations like obesity, diabetes, cardiovascular conditions, and mental health conditions like anxiety and depression. And so really leading to these poor physical and mental health outcomes. And kind of honing in a little bit more on this domain, and we'll talk about, is that there are readily available, you might think about, treatments for this type of physical activity or sedentary behavior or motor challenges, beyond even physical therapy and occupational therapy. So there's abundant literature on the benefits of exercise for neurotypical individuals, for brain health, right? For mood, for cardiovascular diseases, for cognition. Well, that also extends, not as much as should in terms of what's been studied, but to those who are neurodiverse, with autism, with intellectual disability, with ADHD. And these studies have found that there are far-reaching benefits beyond just motor, but in things like cognition and executive function. And at UCLA, we launched our own randomized waitlist control trial of an expressive movement program. And recently, our pilot results are showing the same thing after 10 weeks of class. We're seeing significant improvement in dynamic motor skills, improvements in social communications that are trending, and we're excited over the next 5 years of this study what we might find in broad-reaching domains. So what are some of the clinical considerations when we take some of this information together? Well, I cannot emphasize again how much it's important to evaluate for motor difficulties across a lifespan for those who come into your clinic. A thorough neurological examination, right? Of course, many of us are doing, but in addition to that, what I do in my clinic is, and can also be done via telehealth, is I don't only have a child and an adult walk, but I have them run, because that stresses their gait in a way where it starts picking up things where if they have lower tone or are slower, they might lurch forward or bring their arms up or fall more easily. I always have them try to balance, right, which is fundamentally very difficult for many of these individuals. And I have them do some fine motor task for me, as well as an adaptive skill where I either have spoons or things available and ready, and we look at what their feeding and grasping looks like. And we think then if these are impacted that we might need continued motor therapies, particularly when they may have stopped. Which brings into the next point about gathering information on what therapies currently exist. And what I'll mention here, and I don't have a slide on it, but I think it's important to emphasize, is that under the IDEA Act, the Intellectual Developmental Education, Disabilities Education Act, as many of you know, the school by 3 years of age provides many services, including physical therapy, right? And it's under that unless there are sort of gross kind of deficits in motor function, or what I've heard in lay language, many therapists, psychologists note, particularly in individualized education plan meetings, which is once the child, or this goes all the way to 21 years of age, right, the education, or adult can safely access their environment, there is not need for physical therapy. And so what I mean by saying that is that sometimes we assume they're getting these therapies in addition to speech or ABA or behavioral therapies, but it actually has fallen off for many years, and it might be very beneficial for them to get re-referred to these therapy programs. Screening tools, there are some that are freely available. One is the Developmental Coordination Disorder Questionnaire that a family can quickly fill out. In all honesty, it's not a great questionnaire for those with profound autism or intellectual disability or more global impairments, but there are sections or domains of it that you might be able to pull out to really understand where they're having the difficulty and make sort of a comment into your note why additional physical therapy or occupational therapy should be afforded in the school environment or through the insurance. We talked about referral to physical therapy, also emphasizing that referrals to adaptive organized physical activity programs in their community, again, are often readily available, and if appropriately adapted, can be very beneficial for these individuals beyond just physical activity, but broad-reaching benefits, including participating in things that their neurotypical siblings may be participating in and that the family can take them to as well. We also really focus on the clinic about keeping the individual and the family active. And so we talk about how often are you going for a walk? How often are you riding the bike, if you can? And now thinking about all the other activities that these families might have to do, what we talk about is, how about a 5-minute walk, right, after dinner? How about a 10-minute walk down to the end of the block and back? Just to start getting some incremental physical activity that can be beneficial. And I'll just make one more comment back to the physical activity programs. For the adults that I've seen in my clinic, I have referred many of them to physical therapy because it's been many, many years since they've had any motor therapy. They may be quite sedentary, and it's very difficult for the caregiver to get them out and active. So a formalized program to sort of address a lot of their gait difficulties that they're having can be really helpful in a way to get them back on track to be more physically active otherwise. All right, everybody with me still? We're going to move to our last one and then to our great other speakers. And I'm just going to really touch on this sort of area. So we're going to talk about aging and neurodegenerative conditions in autism and intellectual disability. So, studies have shown now that by 2035, 1 in 5 Americans with autism will be over 65 years of age. And we know from a lot of data that there are higher rates of adverse aging outcomes in individuals with autism and intellectual disability, cardiovascular disease, diabetes, cancer. And recent studies, there have been some from about a decade ago, but recent sort of big studies, mainly retrospective database studies, have reported higher rates of Parkinson's disease and dementia in autistic individuals and those with intellectual disability. But there do still remain limited systematic studies in these individuals. And so I'm going to highlight some of those studies more for awareness around this. So this first one that came out and generated quite a bit of press and interest in 2019 looked at the prevalence of physical and mental health conditions in Medicare-enrolled autistic older adults. This was a retrospective cross-sectional cohort study of Medicare data from 2016 to 2017, comparing the prevalence of physical and mental health conditions in a national sample of autistic adults 65 and plus, Medicaid care data, to a matched population comparison. And what they found, not surprisingly, was that autistic adults had significantly greater odds of nearly all physical health conditions. But when we think about neurologic conditions, higher rates of epilepsy, as we talked about earlier in this talk, odds ratio of 18, but they also found this 6-fold increase in Parkinson's disease. And that really generated a lot of buzz, right, in the clinical field to say, what's going on here? What are the neurobiological mechanisms? What are the sort of long-term impacts of these other health conditions on these individuals leading to this high rate? A similar study a couple years later looked at the prevalence and incidence of early onset dementia among adults with autism. So this was a case control study now using Medicaid data, so different populations you can look at over different age ranges from 2008 to 2012 to examine, as we said, the prevalence and incidence of early onset dementia. These were 30 to 64 years of age individuals, and here what was interesting to see were they had multiple groups, an autism-only group, autism plus intellectual disability, or neither, their sort of comparison. And ultimately what they found was the 5-year prevalence of dementia was about 4% in individuals with autism, 5% in autism with intellectual disability, and interestingly 7% in those with intellectual disability alone, so even higher, but compared to the less than 1% of individuals who had neither of those conditions. Even when they controlled for risk factors often associated with increased risk of dementia, they still found these higher rates in these groups. So again, leading to the fact of what's going on, right? There's still many things we can't parse apart with retrospective data, but these are large samples looking at a range of individuals showing, again, these higher rates that we should be aware of. So I'll kind of highlight is some work that we're doing at UCLA. This is work in conjunction with Dr. Lindsay Shea and Sha Tao at the Policy and Analytics Center at Drexel, and with Dr. Andrew Wilson, who is an adult neurologist and health services researcher. So we wanted to start using one of these data sets to understand, are there neurologic correlates leading to these higher odds of later neurodegenerative conditions? So very early, we're just looking at this data. The first sort of data you see here is in Parkinson's disease. So what we wanted to look at is there an association, which you see in the left-hand column, of epilepsy, sleep disorders, and motor disorders with a later onset of Parkinson's disease? So this is national Medicaid claims data from 2008 to 2016 for all enrolled autistic individuals 40 years and older. And then you'll see a random sample of Medicaid enrollees without these conditions were selected as a control group. And we did also adjust for things like Medicaid group, state, age in here. So this is presenting a lot of odds ratios and confidence intervals, but what I really want to highlight here in our autism column, our AD and autism and ID, then even in our control, that essentially what you're seeing is these conditions are leading to higher odds of Parkinson's disease, right? So just starting to dive in without really knowing more what are the reasons this is happening, but understanding perhaps that these neurologic conditions early in life are predisposing the brain to higher rates of these neurodegenerative conditions, and detecting these things, accurately treating them, motor disorders, sleep disorders, epilepsy, may, in fact, and this is conjecture on my part now, could attenuate or help treat some of those symptoms. So kind of a first step of understanding some of these things that are occurring. So what are some clinical considerations? And I'm going to just kind of touch on these broadly because Dr. Seth Keller and then Dr. Keller, Dr. Arvamutan, and Dr. Sanders tomorrow have an adult in IDDs. I think the first one, which is great, so I encourage you all to attend. Well, they'll be talking about evaluating cognitive decline, for example, in an adult with IDDs. So for the sake of time and also for that, allow them to cover this in beautiful detail, what I want to highlight here is we should all have strong awareness that these conditions are at higher rates in autistic individuals and those with intellectual disability. They may present earlier, and we need to think about screening for these conditions at clinic visits and appropriate diagnoses of these conditions. And I will tell you more anecdotally, I have many psychologists that I work with who say, you know, a lot of my neurology colleagues are hesitant to make these diagnoses in those with intellectual disability or are minimally verbal. So how can we come across what are good ways of screening, or we can discuss that what are the best way to make these diagnoses to get them the support that they needed. I think it's also important for screening, thinking about medication side effects. As we all know, neuroleptics can cause, right, extrapyramidal Parkinsonian-like symptoms. And what I'll tell you is many of the adults that are first referred to me, oftentimes what we're doing in the visit is what can we get rid of, not what can we add, right? There's a long list of medications that have been there for a long time, and we're trying to figure out what they're treating and whether or not they need them. I think a lot of discussion within adult and pediatric neurology needs to continue to occur around these conditions and thinking about processes for screening. And then emphasizing what we've talked about also, which is counseling on lifestyle factors. So the same way you may counsel your patient with epilepsy or a migraine, right, or a movement disorder, we need to be counseling these patients with autism, intellectual disability, and other developmental disabilities on same things. Good diet, appropriate exercise, right? Engagement with peers. So these are all important things for this population as well that we may often forget about when treating about their medical comorbidities or thinking about the other behavioral therapies that they're in. So with that, I want to thank you for your time and attention, and I'm going to go ahead. Thank you very much. And I'm going to move over to our next speaker, Dr. James McCracken. Let's